The second one I won't forget because it was all span of like 2 years. I got this one. Whenever I hear anesthesia called overhead to the emergency room, it means one of my colleagues needs backup or needs help. Anesthesia is not called that often, but some people call more than others. They always want backup. They don't have confidence in our fellow skills. I know when I first started, somehow all the ER doctors working would get phone called quickly to help out the attending who's struggling with the airway, especially if it's a junior intubator, a junior attending, a rookie fellow, or just any attending who had problems, and the nurses would call for us to run in there to help. It takes a while for anesthesia to come down from the OR and bring their skills. Okay. I walk in. Chief resident, senior resident is said he had difficulty intubating a lady who had fallen off a building or jumped or got pushed over a 3-story building and landed on her face, hemorrhaging through the nose and face and mouth. He tried his VL, he just saw blood. I don't know if it was a bloody airway, or if it was his airway that was covered in blood and I see a vertical opening and he freaked out. I'm not sure. He did what he was taught, and he threw a King LT device, SupraGlottic Airway device. It's like a combi tube, and I'll be able to oxygenate with that. That's what saved our life temporarily. I was there and I watched, and the surgeons, or everyone crowded the right side as they're taught to be on the right side of the bed. Chief resident of surgery starting to do a surgical cric because they think that the face is so smashed through the nose, the mouth, that we won't be able to intubate. That was a decision made by the other team, the other ER doctor. The surgeons begin to cut. They're all taller than me. The bed's high. I was like, okay, I'm going to stay on the left side. I'm excited. I think I'm prepared. When there's time to deflate down the SupraGlottic and pull out, we do, and we try to see if the device, because it may impede the insertion of the device, the tip of the King LT being in place. Patient was not desatting. He put the device in, no color change, no end-tidal CO2 wave. So I was like, he must have been on the right track, but something gave. The patient wasn't obese.
Motion detected at the front door.
So then I cut. No, and I go in on the left side. Since I've practiced so much of ambidextrous bilaterally, like with both hands, and doing Cric. Ambidextrous in doing this because I practiced and taught it so much. I palpate. You feel like for Helen, can I look up? I am not tall enough to look down. I'm feeling my anatomy, feel where he had gone. I felt reassured where my anatomy was. I think he went just lateral to the airway, to the correct path, and I cut down. Vertical cut, cut down. I felt with my hand. Now I was always taught to do with the right hand and keep it down. I had my hand leaning on the patient's jaw. And I probably should have switched it up and been cutting with the left, but now it's not my master hand, my dominant hand. It was my right hand. And I grabbed the larynx, and it's cut down. I felt cut down, and I cut. Used the back of the scalpel to dilate. My resident, who saw that I've already taught him how to do surgical airway, he was there at the head of the bed. He's taller. Everyone's watching. I'm feeling for my airway. And I cannulate with the bougie. We put the tube in, 608 tube. The world is as if it stopped. I was just focused on my procedure. I didn't know what was going on other than getting the procedure done. The world kind of stopped, almost like the movie Wanted. Maybe the heart rate went so fast that it became a woo. It just became just following the motions I taught. And then went in, entitled CO2, confirmed it was in the right place. We sutured it down. Later on, I learned how to use a Hollister holder, ET tube holder, to put it up. But later on in the future, not then. We sutured it down. She got her pan scan done because she could never talk to us. She fell off a 3-story building. She was getting admitted, but later died of hemorrhage from the face. Epistaxis was uncontrollable. From the back of the throat, had to pack the mouth, pack the nose. IR was considered, but she died after transfusion in the ICU. And the reason I remember this is I only had one glove on. Because when I took the other glove off, my other hand was caked in blood. Dried blood, her blood. And I felt my palpitations and slight panic attack washing at the sink. No one saw my hands. No one saw my hands shaking. And my senior was FOMO. He was like, I knew, Torres, you were going to be there. And I watched you do the procedure. Sometimes you just got to jump in and help. Save someone else's career and save someone else's patient.